So larynx is a voice box, right? So any disease of the larynx, how do they primarily present to you? Hoarseness of voice. So that is one of the most common symptoms of laryngeal diseases. Any kind of larynx, be it malignancy, be it a non-malignant lesion, be it a cystic lesion, benign lesion, whatever it is. Usually most commonly presents with hoarseness of voice. So, different types of diseases will actually have different extent of hoarseness of voice. Like, for example, you have a small vocal cord nodule. Okay. So the patient may present to you with, say, minor change or alteration of voice. We cannot call it hoarseness. We usually write as alteration of voice. When the patient is probably trying to sing at a higher note, or maybe trying to produce a particular frequency of sound, he is or she is getting some issues. That may be the earlier presentation, but as the disease progresses, as for example there is full formation of the nodules or full extent of the disease, the disease is full blown, the patient may have gross symptoms and you cannot even sometimes make out what the patient is trying to say. Okay, so it can be a wide range of symptoms. So if we divide, this is from a book I guess, the non-neoplastic lesions, it includes the commonest is the vocal nodules, okay, then the vocal polyps, the Reinke edema. So contact ulcers, intubation, Granuloma, Leukoplakia, amyloid tumors, you just know the names. You don't need to know in details of these things. I'll explain when I go through the diseases. I'll explain a little bit, one or two lines. You just remember. But vocal nodules, vocal polyps, Reinke edema, these three particularly come in short notes. Okay, so you need to prepare for this. You need to read these three at least. So now cystic lesions can be ductal cyst, saccular cyst, or laryngocele. Laryngocele can also come as short notes. And then comes a neoplastic lesions, like I said, when there is cell division, right? That can be a papilloma, a squamous papilloma. It can be a chondroma. That is, chondroma is related to the cartilage. So if there is any benign lesion of the cartilage, benign proliferation of the cartilage, we call it a chondroma. There can be hemangioma, a vascular lesion. Okay, so granular cell or glandular tumors, the multiple glands are there, maybe in the saccule, in the whole of the laryngeal mucosa, there can be multiple glands. Then we have abdomyoma, lipoma, fibroma, these are all basic things that can be present in any tissue. Okay, so we grossly divide into non-neoplastic and neoplastic lesions. So, like I said, non-neoplastic lesions means they are not neoplasms, there is no cell division, but they are usually commonly caused by either an infection or a persistent trauma. Okay, so what do we mean by trauma? So say, so when we talk, okay, when we talk, so there is vibration of the vocal cords going on. Okay, the vocal cords come together, they close against each other, and we can phonate. When they're open, we cannot phonate, we breathe. So breathing and phonation cannot go simultaneously. Okay, when we are breathing, we have to open our vocal cords. When we are phonating, we have to close our vocal cords. Okay, so see, repeated trauma, I mean when there is repeated contact of the vocal cords, probably, so there is a particular physiology, when we, if you see, these are the two edges of the vocal cords, maybe the right and the left vocal cords. So when we are talking, we are forcing air from the lungs through the larynx into our oral cavity. So what does the vocal cord do? They just create the sound. Okay, the pitch, the frequency, the loudness, these are created from through the vocal cords. Then the oral cavity, what does it do? It helps us creating words or syllables, because the movement of the tongue, position of the lips, the palate, everything, they help in formation of words. Okay, so when you are saying ah, you are not using your oral cavity, you are just phonating. But for example, you are saying ta 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 ta. You are using the same sound, but you are changing it or manipulating it through the structures in your oral cavity to create a particular sound. Okay, so when we are say phonating, there is a vibrational wave which goes along the vocal folds, medial surface. Okay, so it opens like this. So these are the two surfaces. Initially it opens like this and gradually these waves goes up. So it vibrates like this, the medial surface of the vocal folds. Okay. So now if there is any issue or any abnormality in this vibration, that can cause trauma to the vocal folds mucosa. And gradually, so that is a faulty way of speaking or faulty way of talking that the person is having. Okay, so gradually if this thing goes on and on and on all the time, it can cause some changes in the mucosal structure of the vocal folds. And that can give rise to multiple lesions in the larynx. Okay, so these lesions are usually benign lesions. Okay, because there is no carcinogen involved. You understand what I am saying? So there is no carcinogen involved. Benign lesions causing symptoms. So like I said, infection, trauma or any kind of degeneration. The commonest are the vocal nodules. We also call it the singer's nodules or the screamer's nodules. Why? Because singers or preachers or people who shout too much, what happens is they use their vocal cords in a faulty way. Okay, so normal conversational speech, like I'm talking right now, is the ideal way of talking. That gives the least trauma to the vocal cords. When you are shouting or even when you are whispering, you are causing some trauma to your vocal cords. But most of the times, it's not like we are shouting all the time, right? So most of the times, these are reversible changes and it's taken care of by the body's healing mechanism and we get back to normal. Okay, if you are shouting for a short period of time. But for example, a singer who is probably trying to hit a note or trying to use some notes which is out of his vocal range, but trying to do it repeatedly over a period of time can cause a initially reversible but gradually after repeated trauma causing an irreversible change in the mucosal pattern. Then these kind of things appear which are called the vocal nodules. So there are three stages of development of vocal nodules. First is the stage of exudation, the edema. What happens is there is collection of fluids below the mucosa. Then there is this going on. So the trauma is not relieved. The patient is or the person is continuing to speak in that particular manner, okay, or maybe sing in that particular note. It's trying to force his voice all the time. All the teachers, when teaching the kids, they try to shout a lot to gain attention, okay, of the students. So these things go on and on. Then there is stage of the neovascularization when there is gradual development of vessels. And the third stage is fibrosis or hyalinization. So initially it starts as a reversible change, gradually changes to an irreversible stage where we develop something called vocal nodules. So usually they are very small and classically located at the junction of the anterior 1/3 and the posterior 2/3 of the vocal cords. Why? Because that is the area which has the maximum contact when we are talking. Okay, so that part of the vocal cords is the most important part in creating the phonation. Okay, so 1/3 anterior 1/3 posterior 2/3 junction is the commonest site for a vocal nodule, and it's almost always there. It's almost all the time there. Okay, like I said, they are caused by vocal trauma. Like I said, teachers, actors, singers, vendors, people who shout a lot. Okay, So classically they look like this. This is a very early vocal nodule. So you see both the vocal cords in there, the white structures. Okay. And we have the nodules developing. You see it's classically at the junction of the anterior 1/3 and the posterior 2/3 of the vocal cords. So as they mature, they become more nodule-like. Okay. More fibrous and more nodule-like. So what is the pathology? Like I said, the trauma to the vocal folds in forms of vocal abuse, undergoing first is edema, hemorrhage, and then hyaluronizations and fibrosis, the same thing that I said. And then there is hypoplasia forming a nodule. The clinical feature, the patient presents to you with hoarseness of voice, obviously, particularly initially if it's a incipient on the early nodule, the patient says that, okay, so when I'm talking in a normal voice, I'm fine, but when I'm trying to sing or when I'm trying to teach, I'm having some hoarseness, particularly when I'm trying to force my voice out. Okay, so that's the initial presenting symptom, but gradually as the nodule increases in size, there may be something called a phonatory gap. So if the nodules are not touching each other, the vocal cords are not completely closing. You understand what I am saying? So the two vocal cords are there. So they are not completely closing when the patient is trying to talk. So that creates a space through which the air leaks, and you have a husky voice. It's not clear because your vocal folds are not completely touching each other. There is air leaking through them. Okay. So how do we treat vocal nodules? Like I said, initially the vocal nodules are mostly reversible. Initially. So we always advise voice rest. Talk as less as possible. Okay. And even if you have to talk, try to talk in broken sentences. Don't talk continuously. Maintain adequate hydration so that the vocal cords are hydrated and there is not much dryness or erosions of the cords. Okay. Third is sometimes we give a proton pump inhibitor or a PPI so that there is decreased laryngopharyngeal reflux that can aggravate the symptoms. Okay. And then comes the speech and voice therapy. So normally it's not speech therapy, it's actually voice therapy because through vocal cords you are not creating words, you are phonating. So that's the voice therapy. Speech therapy is usually given when the vocal function is normal, but there is some issue with coordination of words or maybe a child learning how to speak. Okay, then we do something called speech therapy. For here, it's voice therapy. Okay. And if then it doesn't go away with your conservative treatment, then we have to do something called a microlaryngeal surgery, where under microscope we excise the nodules. So there are multiple techniques. I don't think you need to go through all those things, but the microlaryngeal surgery is the treatment of vocal cords which are persistent and not responding to conservative treatment. Okay. So next is the vocal polyp. So it is very important to understand the difference between a vocal nodule and the vocal polyp. Vocal nodules, like I said, see, these are caused by voice trauma mostly. Okay, and it's a chronic voice trauma. So it affects both the sides. While a vocal nodule, a vocal polyp usually appears suddenly after acute trauma, and it is usually unilateral. So what happens is there is a trauma to a particular spot in the vocal cord which causes maybe a hemorrhage or a local edema, and that can give rise to a polypoidal structure in the vocal fold. So this is unilateral because it is not a chronic exposure. It is one vocal cord being affected at a particular point of time. Okay, you understand the difference? So voice misuse, like I said, allergy, yeah, smoking is a very important factor. Vocal nodules are not usually associated with smoking. They can be or cannot be. I mean, you cannot call it a causative factor, but in vocal polyp, smoking can be a causative factor. Usually affects men, like I said, smokers mostly, 30 to 50 years of age. It's unilateral. So it's a soft, smooth, it's a pedunculated structure. Like a vocal nodule, there is hyalinization fibrosis. So it's firmer. It's comparatively much firmer compared to a vocal polyp. A polyp is more like a pedunculated soft lesion. Okay, it can be either sessile or a pedunculated lesion. If it's sessile, that means it's a broad base like this picture. It has a broad base, you see. So it's a sessile polyp. Sometimes it can have a small pedunculated base, and we can call it a pedunculated polyp. And even sometimes what happens, if it's a pedunculated polyp, when you are speaking, if you can do a laryngoscopy and see and tell the patient to talk or breathe or cough, you can see that the polyp may go up and down. But this polyp will not go because it's very sessile. The pedunculated one can go up and down while talking. Okay. So like I said, it's usually a sudden trauma, so a sudden shouting causing hemorrhage in the vocal cords can give rise to this kind of polyp. So clinical features, obviously hoarseness, which is usually acute onset. If it's very large polyp, it can cause difficulty in breathing, dyspnea and all these things, very, very uncommon. Hoarseness is the most common presenting symptom. And treatment, obviously in polyp, voice rest and these things usually do not work, particularly when it's sessile. We have to go for surgery. We have to do a macrolaryngeal surgery. Under microscopic vision, we remove or excise the polyp. Okay. So third, it's very important. Reinke's edema usually comes as short nose very commonly. So what is Reinke's edema? Reinke's edema is also a form of diffuse edema. So if you see the pictures, you will understand the difference. So it's like a polyp, but it is involving a larger length of the bilateral vocal cords. You understand the difference. So there is edema developing in the subepithelial space of the vocal cords, and it is due to any stimulus or any causative agent that is persistent for a longer period of time. So it is usually caused by, most commonly in smokers. Okay, so there is persistent trauma to the vocal folds for a longer period of time, causing diffuse edema in the subepithelial space of the Reinke space. Okay, so it is usually bilaterally symmetrical and very diffuse, involving a longer length of the vocal cord. So treatment is what? So there are conservative treatment, and there is conservative treatment as well as surgical treatment. For conservative treatment, what we do? We do steam inhalation, voice rest, this kind of stuff initially. Sometimes we even prescribe oral steroids to decrease the edema, and we tell the patient to quit smoking immediately. Okay, if the patient quits smoking, is usually aligned with the conservative treatment. Sometimes it may resolve. I personally had a patient he was suffering from a Reinke's edema, recurrent Reinke's edema for a very long time, a smoker, but once he quit smoking, and he still comes and follow up with me. Or it's like 6-7 years, he's doing fine. But usually he used to have 3 or 4 episodes of Reinke's edema every year, and then he'll take steroids, it will go down, and again. So it's very, once you remove the positive agent, the vocal cords usually defines. But if it doesn't respond to conservative treatment, we do something called a stripping of vocal cords. We remove the mucosa partially, and it's more like what we call it a marsupialization. You say, yes, you know what is the marsupialization of any lesion? Okay, so say suppose the lesion is a cyst. Okay, for example, a lesion is like this, a cyst. Okay, it's collected with fluids. So what you do is, you cannot excise the lesion for some reason. Whatever be the reason, you cannot excise. So what you do is, you remove the roof. So it is open. There will be no collection here. It will come out. Right? So stripping, we sometimes do this kind of marsupialization in some abdominal cysts or this kind of thing. So vocal stripping is mostly like that. So we remove a part of the vocal cord mucosa so that there is no edema or collection inside. Because we cannot remove the entire vocal cord mucosa. If we remove it, the patient will have a bad hoarseness of voice, and there will not be any further reepithelialization. Okay, the mucosa will not grow anymore if we remove the entire mucosa. So we have to remove a part of the mucosa. And usually when we operate, we usually operate one cord at a time. So we do the right, for example, the right cord, and then after a month or two, when there is healing of the right cord, we do the left one. But usually with conservative treatment, after the first surgery, the patient usually improves. Many a times we do not need to go ahead with the second procedure. What is a contact ulcer? So when we talk, when the vocal cords are moving, so there is movement of the arytenoid, right? And sometimes these arytenoids touch. If there is like an abnormal way of contact of the arytenoids for a longer period of time recurrently, it can develop something called localized ulcer. Contact ulcers, we find it very commonly. You feel like it can be suspicious, like a punched out ulcer looks bad, but usually the contact ulcers which heals with time. If you give voice rest, do conservative management like steam and stuff, it usually improves. And we also need to do something called uh, complete control of the reflux. There is associated reflux, the symptoms worsen. Okay. So, like I said, the complaints are more or less similar. We do hoarseness, there's constant desire to clear the throat. So, you feel like a foreign body sensation in the throat. You feel like there is something stuck in there because there is an ulcer which is constantly irritating the mucosa. So, feel like clearing your throat. Okay. If the ulcers stay for a longer period of time, obviously there will be secondary granulation and formation of swellings or granulomas. They are mostly not operated. They're usually treated conservatively. Okay. Intubation granuloma is very common thing that we surgeons face many a times. So if there is any abnormal, no, incorrect size of tube introduced during an intubation. For example, in a kid you are using a number 7 or number 8 tube. Okay. Tube means endotracheal tube while doing a surgery. So you're giving anesthesia for a procedure and you are introducing a incorrect size of the tube. Okay, there is a particular calculation as to which size of tube you should be using at a particular age or based on the height and weight of the, uh, details of the patient. There is a particular size of tube that you should use. Okay, but if you're using a size larger than that, or if it's a say a difficult intubation, you have forced the tube through. Okay, you lost the airway, you are trying to rush, you force the tube through. All this kind of situation can cause trauma to the vocal folds and give rise to something later on called an intubation granuloma. Okay. So usually bilateral involves the posterior part. Why? So when we are introducing the tube, like I said, the vocal cords are like V, right? Anteriorly the space is narrow, posteriorly space is wider. So when we are introducing a tube, we usually introduce it through the posterior aspect, because the space is more in there, right? So these intubation granulomas usually occur involving the posterior part of the posterior thirds of the vocal cord and the arytenoid region. Okay. Hoarseness, if large, it can cause dyspnea, like I said, voice rest. Granuloma endoscopic removal is extremely rare. We normally do not do it. Sometimes it is required if it's very large. Okay. See, here is classical of an intubation granuloma. You see the left side, there is a granuloma formation. Okay. So now comes the other diseases of the larynx. These are important for you to know. For example, the most common is a leukoplakia. So what is a leukoplakia? What do you mean by a leukoplakia? So it's a localized epithelial hyperplasia that can happen anywhere, any mucosa. It can be at oral mucosa, it can be a laryngeal mucosa, hypopharyngeal mucosa, anywhere. Okay. So it's basically a pre-malignant lesion. So there is some sort of changes in the mucosa of the organ, maybe the oral cavity or the larynx or whatever it is exposed to. This usually is common in smokers. So then there is mucosal changes. Okay, so that appears usually as a whitish plaque. So it usually appears as a whitish plaque-like lesion on the vocal cord, and leukoplakia is something that you should be worried about because it's a pre-malignant lesion, like I said. The chances of malignancy from a leukoplakia in larynx is higher than in oral cavity. Okay, so you should keep a close eye on the leukoplakia. Okay, so it can appear anywhere along the length of the vocal cord, but usually more common in the middle third of the vocal folds. Okay. It's regarded as a precancerous condition, like I said. Hoarseness, obviously. Then there is leukoplakia. There is the mucosa usually hardens. So there is change in the mucosa, right? So there is dysplasia or some changes in the pattern of the mucosa. So obviously it will not be as smooth or as soft as the normal vocal cord mucosa. There will be some changes. So if these changes are persistent, it will cause change in voice as well, because the mucosal vibration of the vocal folds will not be there. Okay. Like a treatment is obviously stripping of the vocal cords. There are two ways. Sometimes we go for a conservative treatment if it looks very benign, or if it looks like it's very localized. We sometimes keep the patient on very close observation, and every 2 to 3 weeks we do a laryngoscopy, a fiber optic laryngoscopy or imaging, and visualize the lesion, whether it's increasing in size, whether there is any change in character of the lesion, whether there is some redness that's appearing, whether it is becoming more ulcerative or something like that. That is, we are worried about any signs of it changing into a malignancy. So we have to keep a close eye on the lesion. This is one way, and the other is obviously excision of the leukoplakic lesion. But the problem is what most of these patients are smokers. So there is something, a word called field cancerization. It's not applicable to larynx as of now, but for pre-malignant lesions. But so when you are smoking, when a person is smoking or exposed to some fumes which can cause cancer. So what happens is, it doesn't usually touch that particular area of the vocal cord, it touches the entire larynx, right? So there is diffuse change in throughout the mucosa of the larynx. Okay, so if it's not a malignant lesion, you are probably removing only a leukoplakic lesion. You cannot be sure that this leukoplakia will not appear again somewhere else, maybe on the opposite vocal cord, maybe on the retinal region, maybe anywhere, because all the mucosa has been exposed to the same smoke or the same causative agent that has caused this leukoplakia. So there is a field change throughout the mucosa. We do a histopathological examination, obviously to rule out malignancy. Like I said before, it's a pre-malignant lesion. Another thing is the amyloidosis of larynx. It usually is more common in very elderly patients and mostly in male patients. It appears as a smooth or pedunculated mass. The surface is usually smooth. It can cause hoarseness of voice. Diagnosis is obviously it's not clinical, it's histopathological. So, what do you see in amyloidosis? What's it called? There's a particular phenomenon on the pathology which the pathologist can see. You have read it in pathology, right? What's it called? Apple green birefringence, you remember? That is something classical for amyloidosis. Okay, so when the pathologists examine the histopathology, they can with some Congo red staining. What about check? Active 2. So now comes the cystic lesions of the larynx, obviously. The ductal cyst. So all the cystic lesions are mostly retention cysts involving different parts of the larynx. Ductal cysts are like, there's obviously the ceruminous glands present throughout the laryngeal mucosa. Any obstruction can lead to some formation of cysts. So in galliculi, false gouge, piriform sinus, everywhere it can be. It can be there anywhere throughout the larynx. Okay. Usually they are very small, asymptomatic, and sometimes if they are larger, they can cause throat pain and this kind of stuff. So mostly treatment is excision of the cyst if symptomatic. Otherwise, sometimes it's an incidental finding as well. There is an epidermal inclusion cyst. So, like you said, polyp. So, what happens in polyp? The mucosa is involved. Okay. In inclusion cyst, it is submucosal. You understand? So, there is a cyst formation in the submucosal plane. So, it does not. In vocal polyp, there is involvement of the mucosa. But in inclusion cysts, the cyst is usually below the level of the, deep to the level of the mucosa. So, the surgery is also different. In polyp, we just simply excise, but in case of cyst, we usually incise the vocal mucosa, strip it off, remove the polyp and close the mucosa once again. Okay, under microscope. Symptoms are mostly similar. So, saccular cyst, you understand what is a saccule? Like last class I said. So, there is a space. Anyone remember what saccule is? So, if you don't read back at home, it's very difficult to progress further. Okay. So, if there is obstruction in the opening of the saccule, it can cause retention cysts over there. It can be large enough sometimes to cause obstruction in the airway as well. It's usually lateral, but it can come medially and cause obstruction of the part of the vocal cords and your airway. Okay. It sometimes can come out of the membranes and it can present outside. You can also see it outside. When the patient does something like Valsalva or something, you can appreciate the swelling outside as well. Okay. Laryngocele, similar kind of thing. Laryngocele can come as a shortcut. Usually it doesn't come, but you should at least read laryngocele. So it's basically air-filled cystic swelling. So a cyst which doesn't have fluid, it has air. So it can have two parts, one intralaryngeal and one extralaryngeal. So a thyroid membrane, it can come outside and present as a subcutaneous swelling. So when you are talking or trying to force air, there's a nice picture in this book, Dhingra. You can, when you're reading that book, right? Have you bought the book? Anyone? Inachi Shawai? Please buy the book. At least go through whatever is being taught. 10 minutes or 15 minutes will hardly take. If you listen to the class, you know what it is. It takes hardly 15 minutes to recapitulate the things. Just do that. It will be good for you. So laryngocele can have two parts, like I said, the internal laryngocele confined within the larynx, or it can come out through thyroid membrane and cause an external laryngocele. And it's sometimes it's a mixed laryngocele when there is both internal and external parts. It is important because it usually arises from its transglottic air pressure. Hoarseness, like I said, external laryngocele is a reducible swelling because it's air inside. So when you compress the swelling or press it, usually goes inside and it is reducible. And again, when the patient tries to force the air, it comes out as a swelling. So it's very classical, very classical. If you see once in your life, you'll never forget a laryngocele. You cannot mistake it with anything else. It's very classical. Usually we do soft tissue imaging, we nowadays don't do. We do an indirect laryngoscopy. That's a Hopkins or telescope we use, or sometimes we do a CT scan as well sometimes to see what is the positive area. Surgical excision is mostly required and it's through external. So it's a transcervical approach. So we give an incision on the skin, evaluate the lesion, and then go deep in through the membrane and sometimes through the internal part. So this is important. Mass supillation, like I said, will be done. So it is like this, you see. So this is the saccule. It comes out, this laryngocele. It has two parts. You see, this is. So this is the thyroid membrane. Thyroid membrane means this is the hyoid and this is the thyroid cartilage. So this is your hyoid, the first thing. Then is the thyroid cartilage. Between these two. So there is a membrane in there. The membrane doesn't, it gives less resistance than the cartilage or the bone, right? So this part of the cyst can come out or force out through this membrane and present externally. Okay. So see, the patient is doing a Valsalva, trying to push air, and you can very clearly see the swelling here in the neck coming out. And when the patient stops forcing the air through it, it goes down gradually. Some neoplastic laryngeal lesions that induces squamous papillomas, juvenile laryngeal papillomas. So squamous papillomas, like I said, it can be either a juvenile or an adult papilloma, adult onset type. So usually these are viral. The causative organism is virus. So it's usually a viral lesion that can cause multiple small grape-like structures involving both the vocal folds, and is called a papillomatosis. We call it a papillomatosis. These are usually treated surgically because they are very fast growing and sometimes can cause a major obstruction of the airway. Okay. Juvenile type usually, since it's more common, obviously juvenile type is more common in children. So they usually, you cannot appreciate the typical hoarseness, but the patient can have breathing difficulty at times. It can be so bad, so much of obstruction. So usually earlier days we just used to remove, but nowadays we use something called a coagulation so that we can remove the entire disease under vision through a microscope. So glycerine white irregular goes peduncular sessile parapilar breathing. So it looks like a bunch of grapes, bunch of microscopic grapes in there involving both the vocal folds. And one very important thing about papillomatosis is, since it's a viral disease, okay, even and the worst part is, even if even after giving antivirals both orally or locally, you cannot assure that it will not come back because there's a very high chance of recurrence. Many patients undergo surgeries 4, 5, 6 times. Okay, microlaryngeal surgeries and removal of the, because you cannot remove the entire vocal cord. So what you are removing is only a part of the disease, but the infection is persistent. It really causes symptoms and it's sometimes very troublesome for the patient. So nowadays we use something called a CO2 laser, obviously with a coagulation or a CO2 laser, something like that, and they say that interferon therapy helps in decreasing the chance of recurrence. It has been proved that interferon therapy usually helps, but then again it's costly and everyone cannot afford it. Okay, it looks like I said, a bunch of grapes involving the vocal cord. This is a endotracheal tube given in for surgery and they have taken the picture. So these are the vocal cords here, and this is the bunch of grape-like structure completely obstructing the. So you use a coagulator or a laser to remove this thing, and so you cannot remove the 100% of it because it is starting from the mucosa of the vocal cords. You cannot remove entirely. So something will stay back and again come back after a few days. Yes, the worst part. Adult papillomas are much better because usually they're single, not like that bunch of grape kind of thing. It's a single papilloma. It's more like a warty kind of thing. It's very less aggressive and usually appears in from the anterior half of the vocal folds. Treatment is same, but usually they do not require multiple surgeries. Chondroma, you don't need to know much in details. It's basically a benign tumor of the cartilage, like I said. It usually is more common in the subglottic part where the airway is narrower, and it can cause dyspnea, obviously, because subglottis is one of the narrowest parts of the larynx. Okay, so subglottis is not a mobile part, right? It's fixed. So subglottis, any structure in the subglottis, even if it is small, can cause significant narrowing of the airway. Okay, so sometimes they presents with breathing difficulties or hoarseness. Okay, so if it is subglottic lesion, the hoarseness is not very common. It's more like a breathing difficulty and a foreign body sensation, like something is stuck inside the throat. There, the patients try to clear it. Okay. Hemangioma, you all know, it's like a vascular lesion that can appear anywhere in your body, any mucosal area, or it gives the skin or anywhere in the body. Infantile hemangioma, this is something that you should know, at least the name and the presentation. So infantile hemangioma is usually much more commoner than the adult type. So what happens is there is hemangioma formation in the subglottic area. And like I said, subglottis is one of the narrowest parts of the larynx. So if there is a hemangioma, the patient can present with severe breathing difficulties. And this is, sometimes we have to do something like a tracheostomy in these patients to access the airway. It can be that bad because if you are trying to put a tube through it, it can cause severe bleeding and the patient may aspirate. Okay. So usually involves spontaneously, like I said, because it gradually goes down. Hemangiomas usually are left untreated and it can go down on their own. But if it's causing recurrent bleeding or recurrent blood along with cough, then we have to protect the airway, do a tracheostomy and remove the hemangioma. Okay, cauterize it with CO2 laser. Okay, adult hemangiomas are usually more common in the supraglottic larynx. So children or infantile type of hemangioma, they are subglottic. Adult type of hemangiomas are more supraglottic. Okay. The larger ones, like I said, steroid or radiation therapy can be done. Granular cell tumor don't need to know too much. It appears from the Schwann cells. Okay, so nerve cells are always there everywhere in your body. So it's usually submucosal and appears from the Schwann cells. So there is some epithelial hypoplasia. So sometimes it's very difficult to differentiate between a chondroma and a carcinoma in situ. So you are going through gynecology, right? You started gynecology classes, right? So what is mild dysplasia, moderate dysplasia, severe dysplasia? You know all these things? Pathology to পড়েছিস। See, huh? কতটা extent হয়েছে, where it is touching the basement membrane or crossing it. So once it is crossing the basement membrane, it's an invasive type. Okay, till that, when it reaches the basement membrane but doesn't cross it, it's a carcinoma in situ. So well differentiated carcinoma means, what is difference between a well differentiated or a poorly differentiated? And how do you grade it? When the pathologist sees the tissue, sometimes they write well differentiated, sometimes they write moderately differentiated, sometimes they write poorly differentiated. So well differentiated means the malignant tissue looks more close to the normal tissue or the normal structure of the tissue, normal cellular architecture. Poorly differentiated means the normal cell of the normal architecture of the cells is mostly lost. Okay, sometimes even in case of poorly differentiated, we cannot even say whether it is a squamous origin or it's some edematous origin or something, because it's so badly differentiated. So the degree of differentiation means degree of deviation from the normal structure. Okay. Glandular tumor, like I said, anywhere. So there will be glands. There, obviously, salivary glands and everything is there. There can be pleomorphic adenoma, oncocytoma, all these types of other tumors. Okay. So that's all from benign lesions of the larynx. Just go through. It will take hardly 15-20 minutes, maximum half an hour for you to go through these names. Particularly, give stress on vocal nodules, vocal polyps, Reinke's edema. Okay, these are the most common things. If you are given a short note, how will you write? Obviously, what is the disease, the causative agent, symptoms, how do you treat it? So these are the four basic points that you should write your answer on. Treatment, for example, in most of the laryngeal diseases will be voice rest. Okay, and conservative treatment initially. Surgery will be mostly microlaryngeal surgeries for benign lesions of the larynx. Okay, so if it's a CA larynx or a cancer, then obviously the treatment is different, and we will go through larynx, CA larynx. It will be very important class. I think I will expect more attendance, because CA larynx will be in your theory, in your Viva. It's very important. There can be long questions on CA larynx as well. So please, CA larynx will give attention. Benign will be mostly short notes. Okay, but long questions usually come from say Larynx.